Join us here. I want to welcome Dr. Young today to our lecture. She's going to be talking to us about skin findings in children of child abuse. So I will turn it over to Dr. Young to go ahead and get started.
All right, I'm Dr. Young. I'm one of two child abuse pediatricians, and we also have two nurse practitioners on our team. But I'm going to be talking about skin findings and child abuse today. I have a really informal lecture style, so if you have any questions, just turn off your mic, unmute your mic, and shout out at me. I don't think I can see the chat box, so just go ahead and speak out if you have any questions, and we'll get started. All right. So our objectives for today, we're going to cover the 3 B's, which I call bruises. We're going to talk about accidental and abusive ones, bites and how to distinguish if they're animal and human bites, and then we'll talk about burns, accidental versus abuse. So bruises are one of the most common injuries that we see in children. They make up about 70% of the physical abuse cases we see in our clinic. And a good majority of some of our hospitalized patients who come in for abusive head trauma and fractures also have bruises as well. And bruises are caused by blunt force to the skin that cause damages to the vessels that underlie the skin. And then you have blood that leaks out of these damaged vessels and into the surrounding tissues. So one common myth that we get asked often is, does a bruise look like it's new or fresh, or if it's an old bruise? And there have been multiple studies that show that you can't actually date the timing of the bruise because there's different factors that take into effect on what the bruise looks like. So color varies with depth of the bruise and skin color. Some superficial bruises appear early, deep bruises may take days to appear. There are also some other things that you need to take into consideration, like the pigment of the child's skin. So someone my complexion versus someone Dr. Carney's complexion can have the same type of injury, same force, and it can look very different on their skin. Also, if the bruise is located over a lot of adipose tissue versus muscle tissue, the bruise can have a different appearance as well. And then you also want to take into consideration the metabolism and the breakdown of the heme products in the bruise. If someone has a really fast metabolism and their body breaks down those heme products faster, it could go from bright red to yellow green in a day, versus someone who takes a little bit longer. It may take a week for it to get to that yellow appearance. And so it's really hard to date bruises. And so, and hate to be morbid about it, but short of doing an autopsy and cutting into the bruise, you can't really date how long a bruise has been present. So there's some characteristics that you want to consider when you're evaluating bruises. And the main themes that I want you to think about is the development of the child. Does that child's motor skills allow them to sustain this type of bruise on their own? I want you to look at the location. We'll talk about if it's over a bony prominence or not. I'm going to show some pictures that show you pattern bruises. Nature very, very rarely works in patterns. And by that, I mean, if a child is outside running and playing and they bump into something or they fall down, it's highly unlikely you're going to see a well-defined pattern bruise. It's going to look kind of irregularly shaped. And then you also want to look at the number of bruises. So if you've ever been in clinic with me before and I have a little 4-year-old boy that's trying to jump off the exam table and he's got bruises on his shins, he could have 3 or 4 and it may not be a big deal. But if he's having upwards of 5, 6, 10 bruises, then you want to ask a few more questions. So those are the 4 things I want you to consider when you're evaluating a child that has bruises. Is their development such that they can sustain these bruises on their own? Where is it located on their bodies? Are there any distinct patterns? And how many bruises do they actually have? So a phrase that we use a lot is, those who don't cruise rarely bruise. So if you look at the child in the very top left, this infant is probably going to stay in any position in which you put them. And so they should not be able to sustain any bruising on their own unless an object comes in contact with them, such as someone maybe dropped something on them by accident. So if a child of this age and stage has a bruise, you want to ask what happened, because this child did not sustain it on its own. So the second picture of the child crawling is a little bit different. It's highly unlikely that they'll sustain more than 1 bruise on their own in that stage. But if they have any bruising, once they start to become ambulatory, you still need to ask more questions. Once they start pulling up to stand and they're cruising or running, which is the last 3 pictures of this slide, all bets are off, and you need to really get some more history to try to figure out if those bruises are plausible for accidental or abusive injuries. So location. So I want you all to take a quick 10 seconds to read the locations under the accidental column and the location under the inflicted column. So under the accidental column, I want you to take your finger and touch each part of your body that's listed under accidental and tell me what you feel. So if you touch your shin, you feel your hard tibia bone. Touch your lower arms, you may get your radius or your ulna. You touch your chin, you feel that bony prominence there. Forehead is your bony prominence. Your hips are a bony prominence, your elbows and your ankles. All those parts have a bone that is right adjacent to the skin, and it's easy for those parts of your body to get accidental bruises once the child is ambulatory. But if you look at your upper arms, touch that, you don't really feel a lot of bony prominence. Your upper thighs, your trunk, the genitals, buttocks, certain parts of the face, your ears and your neck, there's not a lot of bony prominences under those locations. And so it's hard to get accidental injuries or accidental bruises to those parts of the bodies. So this is not a hard and fast list, but it's a good list to kind of think about when you have a child that has bruises and you want to know if it's possible that they bumped up against something and it was against that bony prominence and it caused a bruise for them. So ear bruising is highly, highly, highly suspicious for abuse. So if you think about ladies or even gentlemen, if you have your ear pierced, how much bleeding did you have after you got your ears pierced? Not a lot, because the blood supply to that part of your body is really, really poor. It's really just skin over cartilage for the most part. So in order for you to actually damage the blood vessels to get bruises on the ears, it requires a lot of force. And so whenever you have a child that has bruising to the ears, you want to think about pinching or pulling or slapping or punching to the side of the face or the head that cause those types of injuries. So your facial bruising. Facial bruising also has a high correlation with abuse. It's accidental bruising is extremely rare. And what I want you to look at in this picture is that this child has bruises to different planes of his face. So if you look at his cheek and you put something flat against the cheek, it shouldn't really curve around to the angle of the jaw, underneath the jaw and under the chin, and then into the recess of the neck. Those parts of the body are on multiple planes. And in order to get bruises on multiple planes, you usually have multiple points of impact instead of just a single fall onto a flat surface. So if a parent told me that this child rolled off of the bed and fell onto a flat floor, and there was no bedside table that he hit on the way down or no toys on the floor that he could have landed on, it's highly unlikely that this child sustained this type of facial injury from falling on a flat surface, because you have multiple recessed parts of his face and multiple planes of his face that have been injured. And for that reason, facial bruising is highly, highly suspicious and correlated with physical abuse. So some patterns that you want to think about when you're having an evaluation for bruises is it symmetric and is it bilateral? Again, if you have bruises on both sides of a child's face, it's highly unlikely that happened from a single simple fall. So if it's on both sides, you want to get some more history, ask some more questions, and it kind of raises your level of suspicion. Again, if it involves multiple planes of the body and if it's not over bony prominences, those are all patterns that are concerning for abuse. And I'm just going to show you a few examples of children that have bruises that should be concerning. And I know in the grand scheme of things, if you have a child that comes in and they're in the ICU and you see some small yellow bruises, you may think it's not a big deal. However, if you think about the location for this one child, I don't know if you guys can see my pointer on the screen, but there are no bony prominences in the areas where you see these circular bruises. And this child was actually had their stomach grabbed by an adult. And so these are actually fingerprints that you're seeing on this child's abdomen, and that's concerning for abuse. And then for the infant that has the bruising on the eyelids, they actually had thumbs pressed into their eyelids that caused these bruises. And so when you have them over locations that are not associated with bony prominences and they're on the face, you want to be very, very concerned about abuse. So some patterns that you may see in inflicted injury is that if a force is applied with an object, the bruise may have two different configurations. It may be the exact shape of that object, or it could be an outline of the object. And I'll show you some pictures of that here in a minute. These are two mnemonics I want you guys to just kind of write down if you have a little notebook that you carry around with you, just to kind of have it in the back of your mind when you're evaluating a child with abusive bruises. Some useful mnemonics to remember is the 10-4 rule or the faces P rule, which means if they have injuries to these parts of the body, you want to have a level of suspicion for abuse. So if there are bruises on the torso, like we saw in the previous picture with the child that had the circular bruise on their abdomen, if there's bruises on the ears, the neck, or bruises on any child less than 4 months old, you want to have suspicion for abuse. Also, if you have any injury, not just bruising, but tears to the frenulum, that can be the labial or the lingual frenulum. You want to think about that. The angle of the jaw, the cheeks, eyelids, if you see any subconjunctival hemorrhages or if anything is patterned, that's another mnemonic for those are locations that are concerning for abuse. So this is just some explanation of that 10-4 bruising model. So the torso has a lot of cushion to absorb injury forces. So direct abdominal blows can cause internal injury without a lot of external bruising. However, once you do see the bruising, then you want to have concern for they had a lot of force applied to that abdomen, and I should get some imaging studies, some liver labs to evaluate for those findings. Again, we talked about the ears not being very vascular. It's very difficult to bruise. So again, a lot of force has been applied to sustain those bruises. The neck is protected often by the shoulder, even sometimes the angle of the jaw. And so it's a recessed part of the body that's really hard to injure from a simple fall into a flat surface. So you want to consider inflicted direct blunt force to that part of the body. And then the 4 part of the mnemonic means bruises in the 10 region for children under 4 years of age, or any bruises in an infant less than 4 months. So this next picture is going to be a good example of how a bruise can take the configuration of the object that caused it, or it can be an outline of the object that caused the bruises. And so I don't know how well it may show up via Zoom, but if you look at the 2 looped bruises on the back of this one child, you can see very faintly that there's 2 parallel lines over this child's shoulders. And that is actually the outline of a linear object that caused the injuries to this child's back. And you can see the same on the second picture of the child with the darker complected skin. And you also can have associated abrasions at the very tips of the looped injuries. And that's because that point of the object had the most force applied. I'm not a physics expert, but something about like distance, and it has a higher rate of speed at the furthest point of distance, which causes more friction, which then abrades the skin. And so oftentimes you can have some abrasions at the most distal point of those bruises. And that was caused by some type of looped object. The next one is a little bit confusing because oftentimes certain patterns can look like looped objects struck the skin, but in fact, this was a child who had injuries from being stepped on repeatedly or stomped on essentially, and it left a pattern that looked like a loop mark. But this is where your history is very, very important. This child came and said that he was made to lie on the floor and then he was forcefully stepped on. And so that's why it's really important when you're doing your documentation and you have these children. If you were to say this child had loop bruises caused by a belt or a cord, and then I go to court and then the child actually said it was from shoes and he was being stomped on, the defense attorney is going to try to throw out your entire medical note because it was documented that this child got hit with a belt when in fact he didn't get hit with a belt. And if the adult got charged for the abuse with the belt, it can get thrown out because it's inaccurate information. So I advise all the residents and even us attendings, when you're describing these injuries, if you don't have the history from the child about what object caused the injuries, just describe it. Don't try to say what you think inflicted the injury. Just say he's got looped bruises all over his back, and you could describe the location in more detail. But don't say belt marks or extension cord marks because you don't know exactly what object caused those injuries. Another common pattern that we see are 2 circular bruises in close proximity to each other. And oftentimes those are from pinching injuries. So they're relatively round marks that correspond with the fingertips of your index finger and your thumb. However, sometimes those two circular marks are not super close together, but this was actually a witness case where it was witnessed that the child's chin was being held and she was being force fed hot food. That was causing burn injuries to her mouth. So, this is still two circular bruises from the thumb and index finger, but not necessarily in a pinching fashion, but more in just a tight grip to inflict more trauma by forcing the hot food. And this child had a lot of oral injuries as well. So also a lot of cases that we see are slap marks or handprints. So kids come in and they have the parallel linear red lines that are consistent with the red bruises. And then you also have presence of petechiae, which is just kind of surrounding those red lines. It doesn't necessarily have to be within the spaces of the hand mark. It can be just in close proximity to the hand mark on the face. And then you have the areas of sparing in between those red lines. And here's some more examples. The one on the left has a really, really good example of associated petechiae with the slap mark on the child's face. And again, you can also notice some redness in the ear. And then the picture on the right is a really, really good outline of a hand. And you have the central sparing in between the parallel red lines. You have another example of the slap mark on this child on the right. This child on the left actually though has what's called a grab or a squeeze mark, and those are usually differentiated by looking at the folds on the child's face. So what happens when you squeeze that child's face, the skin recesses down and it's somewhat protected from having those blood vessels damaged. So the ones that are still on the surface have the red bruises and the petechiae, and the skin that got folded into that recess was protected and it is spared. And so you'll commonly see that in children who have squeezing injuries to their face too. Another common pattern that you'll see is from spanking. You'll have blows to the buttocks, which causes vertical bruising along the gluteal cleft here and here. And then you'll have this associated petechiae as well. And that's very, very pathognomonic for physical abuse and spanking. Another example here where you have the vertical lines of bruising and the associated petechiae on both buttocks. So again, you want to look at the number of bruises. And so we often say children don't bounce. And so we say that because you'll have some caregivers that will say a child had, again, a single fall onto a flat surface, but they'll have 10 bruises. And so there's no way that a single fall can give you 10 bruises in 10 different locations on multiple planes. A single fall should not produce all of those. And so you want to try to elicit more history to account for all the bruises. And if you cannot get that, then you have a suspicion for physical abuse. Some other skin findings that you can have are from ligature marks. We see those a lot in once children become mobile and the parents are trying to restrict them to a certain location in the home. Sometimes they'll tie them to their crib or to a bouncer or something of that nature, and you'll get ligature marks. They're not always on the distal ends of the extremities, but they usually are around the wrists or the ankles. And you can get some bruises associated with those abrasions. And sometimes, if they're deep enough and it's been prolonged enough, you can get lacerations to those parts of the skin as well. Some other skin findings you want to be concerned about are strangulation marks. And you don't have to have a bruise pattern all the way around the neck. Sometimes it's only on the frontal part or the lateral sides of it. So I don't want anyone to think that just because it's not completely circumferential, that it is not a strangulation bruise. It can just be on one part of the neck. But the child gives you a history that they had something restricting their airway, or they felt lightheaded because something was around their neck, and they have a pattern bruise somewhere on the neck area, then you want to have strangulation on your differential. Something we get a lot of questions about are if a child has bruises versus dermal melanosis or Mongolian spots. So bruises can be associated with reddening and inflamed skin, and bruises will eventually fade over time. And again, as I mentioned earlier, short of having an autopsy, you have to cut into these bruises sometimes to confirm the diagnosis. However, We know as general pediatricians, Mongolian spots look very, very different, which is why it's very important for a lot of you general pediatricians out there when you are doing your well child visits for the newborn when they come home to document that this child has Mongolian spots anywhere on their body. You can have them all the way up to your shoulders. You can have them on your extremities, or not just located to the back or the buttocks. So you have to document those really well, because what tends to happen is a child goes to daycare and then a well-meaning daycare worker makes a report to DSS and says this child has bruises everywhere. And then they come to us, and then we have to evaluate them and say that they are Mongolian spots. But another way to make it a firm diagnosis outside of what we already know medically for some of the social workers or for law enforcement is to say, okay, I took pictures on January 13th. I'm going to have them come back in 2 weeks. And then you take pictures again and it looks the exact same. Bruises will tend to have a change in their configuration or their color at that point, but Mongolian spots stay the same. And so that's how we rule it out for our law enforcement partners, our social workers, or guardian ad litems when they come to us. But you as a general pediatrician can really cut a lot of those down if you just document it on day one at your first visit. So I'm really rolling through these slides. So I'm just going to pause to see if anyone has any questions about any of the bruises that we talked about.
Dr. Young?
Yeah.
How important is the timing of photography of these?
So it's always good to take pictures if your institute allows it at your initial evaluation, because what tends to happen is, say if a child comes to you in the emergency department, you've got these bruises and they're going to come to us the next day in our clinic. Sometimes once a family finds out that law enforcement or DSS is involved, they kind of become lost to the wind. They don't want to answer any of our phone calls. And then by the time we can persuade them, either through our charm or through DSS or law enforcement bringing them, it could be a week later and the bruises are gone or they look completely different. And so it's important that photo documentation can happen as soon as possible. Even if a child is coming into the emergency department and myself or Dr. Lamb or one of my nurse practitioners comes over just to take pictures initially, saying we're going to see them in clinic the next day, it's important to get them as soon as possible. And if you can't get photo documentation, if you could describe it as detailed as possible, that helps a lot as well. But photo documentation is very, very, very important, especially if you notice a pattern. Now, if the child has like 2 circular bruises on their forearm, you don't have to take 10 photographs of that because it is what it is. But if you notice like some type of pattern of the bruise, whether it's like a loop mark, or if you can actually see an outline of a shoe or a belt or something of that nature, then it is a little bit more important to take photos at that time. But one circular bruise, I'm not going to say, oh, you should have taken photographs of that. You can document that as it is and we can go from there. Did I answer your question? Okay, cool. Any other questions? All right, so I'm gonna move along to bites. Bites are a little bit more difficult when it comes to forensic value. But when you're looking at bites, basically they have a pattern of 2 arches forming a circular or oval shape. Sometimes they can have abrasions or lacerations associated with them. And sometimes you can have a central ecchymotic lesion, which is basically a fancy word for like a hickey or a suction mark in the center of those. Most of the time, it's not possible to differentiate between an adult and a child bite mark, and I'm going to tell you why. So people assume that whenever you go to bite somebody or something, you actually take the skin all the way into your mouth and it goes all the way back to the molars up to the front teeth and you get the full arc pattern. But say if an adult just bites the child with their central incisors, then it looks like a smaller bite surface, and then people will then assume that it's a child that has bitten this child. And that's not always true. It could just be that the adult used their frontal teeth instead of taking the flesh all the way to the back of their mouth into the molars. And so we stay away from saying if this is an adult or a child bite mark when we're looking at their circumference or the diameter of the actual lesion. What we can say, and I know it's not super satisfying sometimes for our investigators, is this is a human bite or an animal bite, because human bites tend to have a pretty good teeth pattern, dentition pattern, but animal bites for cats tend to just have like puncture marks and that's it. And sometimes dogs have the puncture and then the dragging pattern a little bit. So we can differentiate between bites of a human and animal, but once you try to differentiate between adult and child, it becomes dicey. And then you want to get a forensic odontologist involved to kind of help with that. And that's not for the residents or the attendings to figure out. That's for us to get our SLED investigators to help us coordinate at that point. So that's all I have for bites. Anyone have any questions for that? All right, I'm going to move on to burns. So out of all the burns that are seen, 20% of those are inflicted, and abusive burns are most common in children less than 6 years old. And that's because, unfortunately, older children are able to usually get away from the inciting heat source, or they're unfortunately running from the adult trying to injure them. But 6-year-olds and younger have a hard time getting away from that incident. And so they tend to be the ones that are the victims of abusive burn injuries. The different types of burns that you can get are splash patterns, and I'll show you pictures of some of these, immersions, and that's the most common abusive burn pattern. Then you have your flowing liquids, which sometimes can be accidental, your solid contact, and then less likely your chemical burns in abusive injuries. You see a lot of the chemical burns in accidental, but not so much abusive. Or I take that back, you can also see some of the chemical burns in neglect, like lack of supervision, children getting into some cleaning substances, and it causes some of those chemical burns. So some of the patterns you want to look at when you're evaluating a burn injury is there a uniform depth to the burn? Is there, like the bruises, symmetry or pattern to the burn, or is there a bilateral component to the burn? Is the burn skin versus the uninjured skin, is there a line of demarcation that you could see? Is there a sparing or of the flexural creases or the areas of the body? And then I'm going to show you a photograph of how you can have skin sparing with parts of the skin that come in contact with cooler surfaces. Just to get some nomenclature out the way, there used to be there still is the first, second, third, and fourth degree classification of burns, but a lot of the trauma centers now are going to superficial, partial thickness, full thickness naming of burns. And so the difference is basically your superficial is really, really red skin without the blistering. Once you get blistering present, that's likely your partial thickness. And then your full thickness are the ones where you have the skin is white and leathery. I've got some pictures to kind of show that. Again, superficial is the first degree. The epidermal layer only is the one that's injured, and that's what you can get with like your sunburns. Your partial thickness or your second degree is when you've got the blistering, which is here. You can see under this child's neck. And then your full thickness burns, where you have the penetration into your subcutaneous muscle and your fat, and sometimes even down to the burn, into the bone, excuse me. And that is painless because the nerve endings have been damaged at that point. So this is a good picture of how you can get sometimes a lesser degree of a burn on the point of contact with the material that's cooler than the heated substance around it. So they don't really make these types of tubs anymore, but the clawfoot tubs that used to be made of like a porcelain or ceramic material used to be cooler than the heated water around it. It didn't really take on the heat as well. And so if a child was placed up against that tub, their bottom would have a lesser degree burn than the skin that was exposed to the water, because that material did not heat as quickly and as high as the surrounding water. So sometimes you can have a lesser degree burn. I know this picture looks like it kind of shows sparing of the bottom, but it really just means it's burned to a lesser degree. And then you could also have it where the folds are kind of protected if a child has their legs bent when they go into the water. And then you can see the knees being out of the water, so that have some sparing or a lesser degree of a burn, and as well as the femoral creases as well. If the child's bent at the hip, you can have some sparing of those creases as well, or you could have a lesser degree burn. And I'll show some pictures. So here you see a child that had their legs drawn up, and so the femoral creases and a little bit of their abdomen has, I'm not going to say sparing of a burn, but a lesser degree, probably more of a first degree or superficial burn, because their skin was protected by the folding up of the legs. And then you can see example of this child's bottom is not as severely involved because it was pressed up against the hot surface. And this is just another picture of the examples of these pictures. So this chart is important because it helps you figure out the history, plausibility that the family gives you regarding maybe a lack of supervision and when a child sustained a burn. So oftentimes we'll have children that come in with burns and the story will be, I only left the child in the tub for 2 seconds and I came back and they had these 2nd and 3rd degree burns all over their body. And so what happens is we'll ask our investigators to go out to the home and test the temperature of the water coming out of the faucet and see what the water heater is set on. Because there have been some studies that show that for adult skin, which is a little bit thicker than pediatric patients, but it takes about 10 seconds to sustain a partial thickness burn if the temperature of the water is at 130 degrees. And so if the family says that they just left the room for 10 seconds and they left the hot water running and then the investigators go to the home and the hot water is set on 135, that's a plausible history. But if the family says, I just turned my back for a minute and the child has burns all over and the water heater is set at 120, which is what the AAP recommends families have the water heater set on, then it takes a little bit longer for the child to be exposed to that temperature to sustain the burns. So that's why it's really important to get a really thorough history from the families. And so I'm going to show a picture in a minute that kind of describes this. But what I wanted to explain first is that when you have burns with a child that is clothed, you can have what's called skip patterns. And I'm going to show you what that looks like. So this child actually has examples of a few different things. So first, we've already kind of talked about you can have sparing or decreased severity of a burn in the folds. So she likely had her arm down against her body to protect her axillary skin. But what this child had on when she was doused with hot water was a shirt. And I don't know if you guys ever remember if you've ever been splashed with water while you had a t-shirt on, certain parts of that t-shirt will stick to your skin and certain parts may not. And so what happened is the part that was soaking up that hot water that stuck to her skin, you could see where the contact was. But then this part of the t-shirt probably wasn't up against the skin. This part of the t-shirt probably didn't stick directly to the skin. This part as well, and this part. And so when you have these skip lesions, sometimes it's hard to figure out the mechanism of the injury or how the burn was sustained. But if you ask the parent, well, was your child without a shirt or did your child have a shirt on? And they say, well, my child had clothing on, then this makes sense. If the parent says my child was completely just walking around in a diaper, then this burn pattern is a little bit more confusing. But if she said that the child had a shirt on, it makes a lot of sense. This is like a flow burn or a pullover scald burn. So this child is ambulatory. So I got that developmental history. This child is able to walk around. Mom made a cup of coffee, left it on the end table in the living room, turned around for a minute, and the child had grabbed the cup of coffee and pulled it down. And you can actually see the point of contact, and then it kind of flowed down the child's body and caused this flow pattern. And so that history was consistent with the accidental injury. Another burn pattern you want to be familiar with is that of a cigarette burn. So they have a circular punched out ulceration, which is about 8 to 10 millimeters in diameter. And the severity of the burn is always in the center. And then it's less severe as you go out to the periphery of the burn area. Some other patterns that we see are if you have a lighter that's held up against the skin, even once the flame has been let go, that metal part is still very, very hot. And if it's held up against the skin, it leaves an arch pattern with the central burn in the middle. Next, I have some pictures of some immersion burns. And this is also an example of a child that has bilateral burns. They have a clear line of demarcation. And so that is some of those things that we talked about on a previous slide that you want to look at with your burn patterns. This is another one where you have the child that has bilateral burns, clear line of demarcation, and then this child also has somewhat of some I don't want to call it sparing, but less degree of burns in the folds. This child dorsiflex his feet going in the water. So you have mild protection of the skin here in the folds. And so we briefly talked about just some other types of burns that are really not as common as the scald and the immersion burns that we talked about. So do we have any questions? I flew through that really, really quickly. So we have time for some questions.
Dr. Young, is there a way you can tell the difference between a flow burn that was intentional and a flow burn that was not, or it's really hard to tell?
That comes down to your history. So a flow burn that could be concerning is, I had one in the ED. I can't remember which resident was with me, but it was a 2-year-old boy that had a burn to his face and to his shoulders and down his torso. So it was clearly a flow burn, but the father said he had a cup of coffee on a table in his apartment. And so we had the investigators go to the father's home, and the father actually had no furniture in his home whatsoever. And so the history did not match of this child pulling a cup of coffee off of an end table, because they said this father literally had a mattress on the floor, a refrigerator, a microwave, and that was it in his apartment. And so father's history did not match this flow burn. So if he had gone in and he had an end table that was the correct height for the level of the burn on this child, then that would have been different. But the fact that the investigators went to the home and there was no furniture to be found made that an inflicted burn injury. So to answer your question, it takes more of history and some scene assessment to kind of differentiate between accidental versus inflicted.
Cool, thank you.
You're welcome. Well, if you all ever have questions about injuries and you're not sure if it needs to be an official consult, feel free to call whoever's on call and ask them if they can come evaluate. Just come take a look at a kid in the ED or on the floor, and we'll let you know if it's concerning and if it needs a full consult or not. So you all don't have to always make the final decision on your own. We're here to be a resource for you guys. So always feel free to reach out to whoever's on call, and we'll be happy to help you guys.
Thank you, Dr. Young.
You're welcome.
Thank you, Dr. Young.
All right, well, my email is up there and my office phone number is up there. If you all have any questions, feel free to reach out.